Good. So, welcome. Welcome to the brave people who stayed until the end, even after the end of the meeting for this session. So I welcome you to this IEC Symposium on Itch and Atopic Dermatitis. My name is Robert Bissonnette. I'm a dermatologist from Montreal, and I'm the current president of IEC. If you want to have a look at the agenda for today, if you want to look at the bio from our speakers, please scan this QR code. So we're not providing any paper anymore. I think we don't need it. If you scan the QR code, you will have access to all this information. Great, and then we've already done the introduction. Great. So this session is being recorded. We always do this at IEC. I think it's extremely important, specifically because it's taking place at the end of the meeting and many people have already left. So we're recording it to put it on our website. And always we have many people who will be watching the session in the coming weeks, coming days, and coming months. If you have questions about IEC, you have an info email, you can come to see me or our CEO, Alan Stiles, who's in the room today. You can write to him directly as well. Good. So IEC began 9 years ago. So next year, it will be our 10th anniversary. We are a non-for-profit organization devoted to eczema. What you see in orange are the various countries where we currently have counselors and associates. IEC has been growing. We've also been growing globally. A few years ago, most of our counselors were based in Europe and North America with just a few outside. We now have a better representation in Asia Pacific, some representation in South Africa, South America, Africa, Middle East. We would like to be more present in those areas. So if you are a dermatologist or an allergist, because the association is open to both allergists and dermatologists, if you have a strong interest in atopic dermatitis, if you publish in the area or you do research or you have busy clinics with atopic dermatitis patients, please think about applying to become a member of IEC. We currently have 93 counselors and 33 associates. And these are the various countries where we do have currently associates and counselors, and you can see not only the areas where we have those people, but the number of people per area. So specifically, if you work in one of those countries that are more in the beige color, and you have an interest, please don't hesitate and get in touch with me or Alan or apply directly on our website. So our mission is focused on education and research. We want to educate physicians on eczema, specifically on atopic dermatitis. We want to contribute to atopic dermatitis research, and I will tell you in a few minutes how we do this. So, in terms of education, we've been mostly active at meetings like this one, big international meetings, European meetings, North American meetings, more and more regional meetings. We've been active at allergist meetings where we have symposia on various issues related to atopic dermatitis. I want to thank our corporate sponsors, and I see some faces in the room today from sponsors of IEC. And don't get mad if you don't see the name of your company or your logo on the screen. It's not because we don't want to, it's just because the EADV organizers prevent that. We cannot do this. So you know who you are. Thank you very much, because without you, IEC would not exist. So I talked about symposia. So these are the symposia where we have been present or will be present in 2023. And these include the allergist meeting that took place in San Antonio, where we had, where we had an in-person symposium. We were also present at EADV with a symposium on prurigo nodularis, at ISID, where we talked about pathophysiological insights of atopic dermatitis and new therapeutic developments. We had an in-person symposium in South America at the RADLA meeting, where we talk about comorbidities. At the World Congress of Dermatology, we talked about non-atopic challenges in AD patients. Today we're talking about pruritus, which is something that is key and central to atopic dermatitis in an area where there's been a huge amount of development over the past few years. We will be at the ISDS meeting in Vienna with a symposium on basic research techniques in atopic dermatitis. We offer fellowships, so we have a fellow who will start in Canada with one of our counselors, a one-year research fellowship, Dr. Merolino. In 2024, there will be a U.S. clinical fellowship, so this is a one-month fellowship for people who are more interested in the clinical aspects of atopic dermatitis. We will also be announcing soon a research fellowship, which will be a one-year research fellowship, and this will be open to international applicants. So this will not be restricted to people who want to work in the US, Canada, or elsewhere. It will be open globally, both for applicants and for counselors and associates. Manuscript and special projects, we have a number underway. We publish on a regular basis. If you're a counselor or an associate and you have an idea in terms of publication or in terms of project, don't hesitate to submit. So you can have a look at our website and make a submission. If you want to discuss with me, our president-elect, Alan Irvine, or a CEO beforehand, please don't hesitate and reach out. Any general questions about IEC can be directed towards our CEO, Alan Stiles, who, for those who don't know him, is standing at the back right now. So if you're wondering who he is or you want to get in touch with him, he's the man standing at the back. Very good. And now I will introduce our co-chair for today. In fact, she doesn't really need introduction in a session that is geared toward pruritus. So she's one of the world experts on pruritus. I need to be very careful today because I cannot, I know that there are many world experts on pruritus in the room, so I thought about using the word queen, and then I said it's probably not relevant anymore, and I say king, then I have an issue as well. So I will stop here and just say that she's more than well known. She's one of the few people, dermatologists I know, who have a very strong background interest and works significantly in the basic mechanisms of the disease, but is also highly interested by the clinical implications and clinical research on pruritus as well. She is currently a professor of dermatology and neurodermatology at the University of Münster, Germany, and she is heading a pruritus center at that institution. Sonia. Be careful with the pointer, it tends to slip.
Robert, thank you very much. That was too much. Yeah, ladies and gentlemen, also from my side, a warm welcome this afternoon in Berlin, and on behalf of Gil Josipovic, also a person that don't needs in-depth explanation and presentation. I welcome you here to this workshop. So we are very grateful to the IEC to pick this topic, the itch in atopic dermatitis. And we picked it because atopic dermatitis is maybe the disease where the itch induction, transmission, and perception is best studied and best understood. So what we want to present today is a deep dive into the pathophysiology of atopic itch, starting with the interleukins and then the role of the nerve fibers and the brain. So you have the full route from the skin to the brain. And then we circle that back. How can we influence this by topical and systemic treatments presented by Robert? And a very, very important topic, and therefore it comes at the end, that you stay here until the end. How can we make the people happy, and what does that mean for the quality of life of the patients with atopic dermatitis? And I'm very, very happy that we have here Alexander Singh, who is really now a global expert for this topic. And I did not mention one name, and this is Mette Delorme, because she's the first speaker and a good friend of mine. She's coming all the way from Denmark, from Aarhus. She is in fact a founder of the International Society for Atopic Dermatitis, so we have a really also very, very good expert next to Robert on the disease itself. And she is a wonderful basic researcher, EADV previous board member, member of the guidelines. Shall I continue, or do you want to start with a talk? Okay, come on.
Just click maybe with the mouse. Like this, yes. Yeah. Thank you, Sonja, for this very nice introduction, and I would like to thank you and Jill and also Robert for inviting me to this IEC symposium. It's a great honor to be asked, and I think I got a little difficult topic because there's so many cytokines, and what I'm going to concentrate is a few of these, how we can think about it in terms of atopic dermatitis. I have these disclosures because I work with companies on new treatments for atopic dermatitis. And in the AD development, we find a disruption of the immune balance leading to pathophysiological inflammatory responses and structural changes of the skin. And we know there's a strong genetic disposition for getting atopic dermatitis, but also environmental factors contribute to this balance and also infections. We have a subclinical dry skin inflammation in the beginning, leading to symptoms of atopic dermatitis. The diagnosis is established later, and then we also have a lot of comorbidities, and I have just mentioned a few like rhinoconjunctivitis, asthma, allergies, and also psychological disturbances, which are quite prevalent in AD patients. Regarding the cytokines, we have many different cytokines involved in this process, and we have the type 2 development. We also have other Th17, IL-22, and also Th1 responses. I'll come back to that a little later. But we have the OX40, and maybe you just heard a wonderful presentation by Professor Stefan Weidinger from Kiel, that we now have this particular response, which is now elucidated and maybe leading to treatments. We have, of course, IL-4, IL-13. We all know about that response, and IL-25 is also one of the examples. We then have the effector molecules, like also involving TSLP, and we have the structurally related changes which we see in AD patients, skin barrier function, and all the loss of function of filaggrin, to give an example. So we have all these kinds of things involved in the pathophysiology and the interleukin march in AD. So what about the genes and the environmental factors? Well, I'm not going to go into so much about the genes, but we know there's a strong inheritance, and 70% of patients suffering from AD have some other family members suffering from asthma, maybe hay fever or AD. So I think this is a very interesting publication which came from Emma Gottman's group a few years ago, and that is that we shouldn't see the patients as just a homogeneous group. We have many different phenotypes and endotypes, and therefore maybe we should approach them a little differently when we want to treat them. For instance, in Asian AD, we see a lot of upregulation of Th22 responses, also Th17 compared to patients of Caucasian origin who have not so high IL-22. And we see a hyperkeratosis mostly in Asian patients. Also, we see it a lot in African patients, and looking a little similar to psoriasis. So we need to be aware of this if we want to treat patients properly, to see that there are some differences if you come from different places. I'll give you an example of TSLP. TSLP is highly expressed in the epidermis of atopic dermatitis, and it also has a link to environment because TSLP production in the upper parts of the epidermis is induced by allergens, microorganisms, secrets mode, for instance, and also by irritants. And it has been shown, I think this is a very interesting data, that children have elevated levels of TSLP at 2 months of age if they develop clinical AD at 24 months of age. So it's sort of a predictor that it's an early activation of the immune system. People have tried to treat with anti-TSLP. It has not been so successful, but it is very heavily involved in AD. Also, microbiome is important, and this is an old study from Heidi Kong, but very well known because it's so interesting that if you alter the microbiome by Staph aureus, we know that many patients suffering from AD, up to 80% of patients are colonized on the skin. Not so many patients or persons from the normal population have Staph aureus on the skin. Maybe they have them in the nose or around the anus, but not so often when you have a normal skin. But if you have an AD skin, you are often colonized, even though you don't have a clinical infection. But if you have a flare of your AD, there's a dominance of Staph aureus in your skin during your flares and a decreased microbiome diversity on the skin. And as an example of this, how it goes together with this inflammation and cytokine response, there's been a study that showed that entry of Staph aureus into the epidermis directly correlated with an increased expression of key cytokines IL-4 and IL-13 and IL-22 and TSLP in a mouse model of atopic dermatitis. And if you look at this, this graph here on the right side, you can see that if you add Staph aureus to the cells, then the IL-4 goes up a lot. But if you also add lipids to the surface of the skin, then it's not so highly expressed of IL-4. So this sort of also proves that we still need to give patients emollients. It helps a lot on the inflammation. What about the type 2 development of our patients? And these are just examples from our clinic, and hopefully patients will not have so severe eczema in the future due to that we can better get control of the disease nowadays than we used to be able to with the things we had in our toolbox before. So we heard about the OX40 ligand system, and we published a paper with Regina Förster-Holst also a few years ago, where we looked at is OX40 and OX40 ligand presenting cells actually present in AD skin, because we need them to be together to interact with the antigen presenting cell and the Th2 cells. We need them together to be able to activate the immune system. And we showed here that we have, these are the nuclei, these are the blue, and we have the red anti-OX40 and the green color is anti-OX40 ligand. So certainly cells are together in the skin presenting these antigens. And another thing is that we also showed that OX40 expression is increased on skin-homing T cells in patients suffering from atopic dermatitis. So the OX40 system in AD, OX40 expression is increased on skin-homing T cells in patients suffering from AD. We know they are co-localized in the skin, making sense that treatment would help. And we have just seen at this Congress as late-breaking abstracts also, but phase 2 trials have shown that both OX40 and OX40 ligand inhibitors have shown promising results in phase 2 studies, and I'm sure we'll hear more about it later, and also a maintained clinical response after treatment was stopped. So I think this is an interesting new pathway regarding the cytokines in AD. We have done some studies on interleukin-25. It's another example. We know it's also known as IL-17E. It induces IL-4, IL-5, and IL-13 in mice, and transgenic mice who express high numbers of IL-25 have eosinophilia and increased IgE, things we also see in atopic dermatitis, and mRNA for IL-25 is present in the skin. We did some studies formally, and we showed that IL-25 is elevated in AD and correlates with the EASI score as shown on these graphs. And just to give a connection to IL-25, it's more than just a Th2 development cytokine, but it also is an effector molecule. And this is an example from a publication we did in the JID many years ago, that if you increase IL-25 in a concentration solution affecting keratinocytes, you can see that IL-25 reduces filaggrin mRNA synthesis in keratinocytes if you increase the concentration in your culture media. So it makes sort of a connection with the skin barrier function and the inflammation. And it decreases filaggrin synthesis, as we have shown in keratinocytes. We also found that it was upregulated on mast cells, inducing Th2 responses. So it's part of the pathway. Some companies have tried to develop treatments against IL-25, and it had some effect, but I think they abandoned it because some molecules were better than this pathway. But it is involved in the response. So what about the effector molecules and the barrier dysfunction? Well, we know that a lot of these alarmins, IL-1, IL-33 and other, activate the Langerhans cells in the epidermis and leading to a Th2, but also to a Th17, Th22 and Th1 response in the immune system in the skin. So we played around a little bit with an in vitro model of human keratinocytes. It's an air-liquid skin model with fully differentiated epidermis, so you can see all the layers of the epidermis. It doesn't have a dermis, but it's cultured on a membrane in an air-liquid interface. And what we found was that if we add IL-4 to the culture media, we see downregulation of filaggrin, loricrin, and involucrin, three of the most important barrier proteins found in the skin. So I think it's very visually that you can see that you have much less filaggrin expression here, loricrin expression, and involucrin expression if you add IL-4. So it destabilizes the barrier function. So we have these key components of the skin, and we have a model here shown by Lisa Beck and co-workers who did this publication in the JID. And here you can see atopic dermatitis skin. Here you can see healthy skin. So we have an altered lipid synthesis in atopic dermatitis. We have leaky tight junctions, and we have a permeable basement membrane allowing irritants and allergens and microbes to enter the skin and inducing the immune system. So we know that there are key cytokines that are involved, IL-4, IL-13, IL-31, IL-33 as examples, downregulate the epidermal barrier proteins, and also these filaggrin, involucrin, loricrin, and it leads to a disruption of the epidermal barrier function. So I think this is an interesting observation, because what about filaggrin? This is a nice publication from Leclerc group who showed that filaggrin breakdown products like natural moisturizing factor are lowest in the cheeks compared to the tip of the nose in the first year of life, and that the cheeks mature much slower regarding filaggrin compared to the tip of the nose. And I thought about this old sign who Professor Yamamoto described a long time ago, that the tip of the nose is always spared in atopic dermatitis. And if you look at babies, they never have atopic dermatitis on the tip of the nose. And I think that could be an explanation for this. So what about skin barrier disruption and type 2 inflammation in AD? And this is a busy slide also from a very nice publication by Lisa Beck. So we have all these components which can be affected by the type 2 inflammation. We have the keratins altered, we have filaggrin going down, all the other barrier proteins also going down. We have the microbiome altered, increased proteases, natural moisturizing factor going down, the tight junctions are weakened, and we have the skin pH going up, which is not beneficial in atopic dermatitis, and a disruption of the lipids. So many different factors are involved in AD and the development of AD. So can our knowledge help us to understand treatment mechanisms in AD? Well, an example of that we have, an example I would like to draw your attention to is that we have different treatments blocking IL-4, IL-13, which are some of the key cytokines. And we have also a decoy receptor, which are membrane-bound receptors that do not lead to signaling. We have a similar system in interleukin-1. And this hinders future binding of ligands to other signaling membrane receptors. And this is an example. We see here the IL-4 receptor on hematopoietic cells. We see here on epithelial cells, and then we have this on structural cells. And this is the IL-4 and IL-13 receptor and their signaling pathways. And we have the IL-4 signaling pathway first on the hematopoietic cells and epithelial cells, but IL-4 does not bind to the decoy receptor of IL-13, of course. It cannot. So it doesn't, it binds to the, IL-13 binds to the decoy receptor, of course. I'm a little ahead of my talk now. But if you have dupilumab, it blocks IL-4 receptor alpha, interfering with both IL-4 and IL-13 signaling. So you have dupilumab binding to both IL-4 and IL-13 receptor, but dupilumab does not interfere with the IL-13 decoy receptor. If you have tralokinumab, it targets only IL-13 and prevents binding to both receptors, the IL-13 receptor alpha-1 and the IL-13 decoy receptor. So it does not interfere with IL-4 signaling on the hematopoietic cells, but it does interfere with IL-13 binding to IL-13 receptor 1 alpha, and it also binds to the decoy receptor. Lebrikizumab, which is also targeting IL-13 only and not IL-4, it does not interfere with the hematopoietic cells. It binds to the IL-13 receptor alpha-1 on epithelial cells, but it does not interfere with the IL-13 decoy receptor. Maybe that explains some of the differences in results when you treat with these different targeted cytokine treatments. So the development of AD, the disruption of the immune balance and the pathophysiological inflammatory response and structural changes we see in AD, if it continues, you have a chronic stage of immune activation leading to all these comorbidities and chronic disease. It is a chronic state of multiple cytokine mechanisms, which I showed you in some of the overviews of all the cytokines being activated. And I think we need to stop the cascade leading to chronic inflammation and structural skin changes. And we sometimes talk about if we should hit hard and early to prevent this march of chronic inflammation and barrier destruction. But I think we have a lot of good tools now compared to 10 years ago, and we are still getting a lot of interesting new treatment targets, and I think Robert is going to talk to that later, about that later. So I would like to thank you very much for your attention.
Mette, thank you very much. We have now time for questions. As usual, you can use the app to send us questions here. At the moment, we don't have one, and so if there's no question at the moment from the audience, Mette, I might start with a little bit a provocative question, and then we have a question from the audience. So the answer can be very short or very long, you decide. So the decoy, the IL-13 decoy receptor, in animal studies we have hints that it's associated with somehow scratching, but do you think about the human situation? Do you have any clue to the receptor function?
It's difficult to say, but if you look at the clinical data, it seems that if lebrikizumab is blocking more effectively the system and the inflammation, we have higher responses compared to tralokinumab, for instance. So I think there must be some kind of differences. We know that lebrikizumab has high affinity to IL-13. Maybe there's a longer response in terms of that. And we also see that there's a high response after stopping the treatment. So that's sort of my interpretation of it. I don't know if you think otherwise, Sonja.
And no, I don't think otherwise. So we are playing around with hypotheses for what the receptor is good for. And so we cannot replicate what has been done in animal studies, that if we take a look at scratched skin, we don't see an upregulation of this receptor.
So that's interesting observation, yeah. Thank you.
Please.
Yeah? No, not, sorry. Is there somebody who can?
Microphone?
Yeah,
Yes.
that's much better.
So my question is related to the type 1 receptor, because type 1 receptor is present in hematopoietic cells and not epidermal, but we know lymphocytes, non-activated lymphocytes, and lymphocytes T only have type 1 receptors. They don't have type 2 receptors.
Okay.
So the initiation, we know type 2, we know the Th2 are very, very important in atopic dermatitis, right? So my question is related, how do you see the value of IL-4, knowing that's only IL-4 will be the one activating the lymphocytes in atopic dermatitis pathophysiology?
I'm not exactly sure what you're asking me to answer.
The IL-4 is hematopoietic cells, but this hematopoietic cell includes the lymphocytes.
Yeah.
Not read.
We know the lymphocytes are very important in atopic inflammation, so I think certainly if you block IL-4, you get maybe a stronger response in blocking the inflammation in atopic dermatitis. Could be, but when we see the outcomes of the different treatments, it's difficult to see in reality. So we can make experiments in the wet lab, but when we come to clinical differences, it's very difficult to predict, like Sonja says also with this IL-13 decoy receptor, that sometimes we predict some theoretical things, but when we see it in practice, it's difficult sometimes to follow it.
Mette, I have another question for you, a nasty one.
Okay.
This is a really nasty one.
So maybe you should answer it yourself.
And I hope Gil will help you here. So you nicely showed that there is a barrier disturbance.
Yeah.
How does the barrier disturbance alone induces itch?
This is a very difficult question.
A very nasty one.
It is indeed. I don't know if you can explain it, but from a clinical situation, if you look at elderly people, they have very dry skin and they have cracked skin and they itch a lot. So I don't know what exactly the mechanism is, but certainly this open barrier which is penetrated to irritants, allergens. So I think this can activate the immune system, activate the cytokine cascades, and therefore we can induce an itch, activating interleukin-31, which is called the itch cytokine. So I think in a way it makes sense that if you have a disrupted barrier function, you get all this activation of the immune system leading to itch. But I'm happy if Jill can supplement on this.
Yeah, okay.
Yeah.
I'll try to give my point of view, but I'd be So clearly, I don't see dry skin equals itch. So to me, ichthyosis vulgaris without the atopic never itches. So there is a component, clearly, that could activate it. I believe that the phospholipases and the kallikrines have a significant impact in activating proteases, also in staph in addition, activates proteases and the non-histaminergic pathway. The pH changes are really important also in terms of activating these nerve fibers in the part 2. So there's a lot of things. And then IL-2 kind of interacts there too. The type 2 cytokines, because they also have an effect in intensifying the damage to the barrier. So it causes a vicious circle of activation. So there's more to learn, but it all interconnects.
It does indeed, so it's a maze, sort of, yeah.
But what you just said, I think it's very interesting to check if we have in dry skin an upregulation of interleukin 31. I'm not aware that anybody checked this already, and this
Would be interesting, wouldn't it?
very
Yeah.
interesting.
Yeah.
Yeah.
Also because we have so many patients with pruritic skin, not maybe AD, but many other disorders, and I think it makes sense. Yeah, we should do that.
Just a small, we can have a symposium on dry skin and atopic, but the TRP channels also, they're part, in particular TRPV3, most probably it's actually more in psoriasis, but it's also in the barrier function, and TRPV3 is highly associated with itch and is overexpressed in damage to the barrier, and therefore there's so many interactions. So these are ion channels, and again, it could be also a crosstalk between the nerves and also the immune cells activating the TRP channels.
It's interesting because in our old textbooks it said that psoriasis patients never itch, but I think it's not true. I think
Totally not true, sorry.
so that's just an observation from the clinic, yeah.
But I have a question to you, what are you most excited? And you had a beautiful presentation of all the pathophysiology, but what would you, in terms of your wet lab and work, and also as a clinician, what would you be most excited from all the molecules and targets in terms of the antipruritic effect of?
I think certainly that, that's not cytokines, but JAK-STAT inhibitors are very efficacious blocking itch on a very early stage. I think the nemolizumab is certainly, I didn't mention that, but I think that's certainly a very interesting molecule because it blocks what we call the itch cytokine IL-31. But other treatments like the biologicals, they certainly also help on the itch, maybe slower. So I think we have now many more sort of efficacious drugs, and then I know there are other molecules which I'm not so familiar with, but I'm sure we'll hear more about it in the symposium. But I think certainly we have a relief of patients who we were not able to help before, also the PN patients who also sometimes have atopic dermatitis on top of it. That we have the height form, which is sort of the very clean form, and then AD with prurigo nodules. And I think we can help both of these much better now than we could before.
Thank you. A great presentation, Professor Deluran. I just wanted to clarify one information on the affinity and the binding affinity between trilocylumab and this IL-13 alpha-2 receptor, so-called decoy receptor. And based on the data that were published last year at SID in Portland, trilocylumab does not affect the physiological function of the decoy receptor because of the different binding affinity. The way that IL-13 binds to decoy receptor is at least 1,000 times higher than the binding affinity between trilocylumab and IL-13. So we believe that naturally IL-13 will bind to the decoy receptor, maintaining the physiological natural function of this receptor. Then IL-13 will be bound to trilocylumab, or trilocylumab will bind to IL-13 and neutralize it. Okay. And also one more thing, the binding affinity between IL-13 and trilocylumab and IL-13 and lebrikizumab is within the same kind of range, so the differences are minimal. And I fully agree with you, all of the data were created, ex vivo or in vitro, and should not be directly extrapolated.
No,
into
it's
the
difficult
clinical.
to say,
Yes.
but thank you very much for your input.
Mette, a very, very good job and tough questions. And thank you very much. You did brilliant. And now we move on to the nerve fibers. And we all know that itch is a typical hallmark of atopic dermatitis, but the patients have more. They frequently have an itch scratch cycle, so they have the high intensive itching during day and night that clearly worsens the quality of life. But scratching also worsens the quality of life because it induces in itself excoriations, bleeding, crusts, and so this also impacts the quality of life. Many patients scratch unconsciously during the sleep, and by scratching we further worsen the barrier function, promote the eczema, and then we promote the itch, and then we are here again and the circle starts again. So, but what is the influence when we scratch, when we use our fingers or other scratch devices on the nerve fibers itself in the skin? And you know, the nerve fibers in the skin can be classified into large fibers, small fibers, autonomic fibers. And among the group of the small fibers, we also have different classes, for example, as we stratify them by having more myelin sheets or less myelin sheets, but these are clearly the nerve fibers that transmit the itch and the pain signal. These fibers have not only the efferent function of submitting some signals to the brain, they also by themselves can release substances when they are activated, and this is called efferent function, and they release mostly neuropeptides. And of course, these nerves are in a micromilieu, here in the epidermis, but also in the dermis. They have many receptors, and so they are target to our inflammation on every level where they are anatomically. Interestingly, they have close associations to surrounding fibers as to Merkel cells, this is also called a unit, and to Schwann cells, of course, surrounding them. And these cells have more influence than just being anatomically close. So, for example, the Schwann cells are more and more investigated in the skin, and it's already known that they contribute to a growth or a reduction of the nerve fibers and also to onset of neuropathic pain. And of course, our keratinocytes have an influence, as we just heard from Mette. But the nerve fibers also influence the cells that are around, as the mast cells. Mast cell degranulation is promoted by the neuropeptides that are released by the nerve fibers. And here is also a very important association to dendritic cells. Psoriasis onset would not be possible without nerves because they release substances that activate dermal dendritic cells, and then the psoriasis inflammation starts via interleukin 23 and interleukin 17. So what are the mechanisms in atopic dermatitis? And when we see these graphics and we see the lists of mechanisms that are involved, that's all very clear to us. But we also have to consider the dynamics, and this is given here. So we have several steps. We know the genetic background, and based on this, with triggering factors, there is onset of the inflammation, and you see here the itch that rashes and the rash that itches, it's all in there. So the eczema produces itching, but scratching can worsen the eczema. And this leads to what we just discussed, barrier disturbance, but also with ongoing scratching to lichenification and to more. And the more is what I would like to add today. We have a nerve degeneration based on scratching. This knowledge came up 10 years ago in animal studies, and my key message here today is also that animal studies always differ from the human situation, because in animal studies we clearly found that when the animals scratch, there is an increase of the nerve fiber numbers, and when we are doing topical therapies, for example, here with SEMA3A, that is a nerve repulsive factor, then the nerve fibers can normalize to normal levels. This was the animal situation, and we thought it must be the same in the human situation. And so it was very controversial when the first studies have been published that we see a reduction of the nerve fiber numbers in the epidermis when we are applying the validated methods that is also used in neurology to determine small fiber neuropathy. And this is a method called determination of the intraepidermal nerve fiber density. And you see here some results. In atopic dermatitis, there is a reduced nerve fiber density compared to healthy controls. And this was not only observed in atopic dermatitis, but also in other itchy conditions as a neuropathic entity, brachioradial pruritus, prurigo nodularis, and healthy skin. And you see here very clear differences to matched age and gender matched healthy volunteers. As this was controversial, many more studies have been done, and this is a confirmation of patients with atopic dermatitis. And to really show that it is a true effect we are seeing there, we took 3 skin biopsies of the patients. We took a biopsy of a lichenified pruritic atopic derm area, a non-lichenified area, and a non-pruritic, non-lesional area. So 3 biopsies, and we are very grateful for the patients that participated. And you see here kind of a gradient, an increase of the nerve fiber numbers, the less the lichenification is. Here we have the lichenified, non-lichenified, non-pruritic, non-lichenified, and here we have the matched controls. And so there always were significant differences. So along with scratching, it seems that we have a reduced nerve fiber numbers. Together with Gil, we then use this knowledge to create a clinical trial in atopic derm patients that have been treated with dupilumab in an open label studies, and we regularly took skin biopsies to observe if we are right and if a treatment can change the situation. And we really saw again a decrease of the nerve fibers compared to healthy controls, and along with the treatment, and we are discussing here 16-week treatment, there was an increase of the nerve fiber numbers. This was significant. So we again had here a kind of a confirmation. Here are some images, and what you see here are the nerve fibers. We also have here a heavy background staining that is due to the photography we provide here. The specimen where you determine the nerve fiber numbers are very thick, that you can do it the floating microscopy technique to really find the nerve fibers. And so this explains why we have not so beautiful images here, but you can believe me that these nerve fibers are really there. And so you see here the number. We count only those nerves who cross the basement membrane, and here we see the baseline AD, we see end of treatment after 16 weeks, and here the healthy controls where we see better the nerve fibers in the epidermis. So this confirms previous study on prurigo nodularis. We did this before with Svetlana Bobko, a colleague from Russia, and she investigated lesional skin from prurigo, interlesional skin, and non-lesional and healed skin. And we see a full restoration of the nerve fibers after complete healing of the lesions. So I have to mention here, as Gil is here, this idea was born in Gil's head. Once again, he was the first to describe that. You see here a paper in the British Journal of Dermatology from 2008, where he observed this already in lichen amyloidosis and later in nummular eczema, that the nerve fiber numbers are reduced. And together with his colleague from Singapore, he did a 3D approach to confirm that the nerve fiber numbers in atopic dermatitis and psoriasis are reduced. This is what they could confirm here, you see a good example, lesional, non-lesional in AD and psoriasis. And they also measured the fiber length per unit volume in these entities and also saw a difference. When we transport this information back to our 2D approach, we can present more interesting findings because there must be a reason that so many reported an increased sprouting with interleukin 31 when they give it in the DRG cultures. So where is the sprouting? And the sprouting is within the epidermis, so the single number of nerves crossing the basement membrane is reduced. This is a reduction of the intraepidermal nerve fiber density. But if we look at the single nerve fibers, we see that there's an increased branching. And you see here this example, look how branched these nerve fibers are. And the most heavy branching we see in patients with prurigo nodularis or chronic nodular prurigo. This is here the abbreviation. We also see increased branching in brachioradial pruritus here. And we also see a little bit more branching in atopic dermatitis, though they have not the most fibers being branched. They have more linear branches, more comparable to healthy controls. We dive deeper into that with our 3 biopsy approach, and there we could confirm that in the lignified skin, so where there is the most scratching, the branching is most intensive compared to non-lignified areas compared to non-pruritic, non-lignified areas and healthy controls. And again, you see a gradient here in the nerve fiber branching. So we think that we really found a hint that scratching from outside can change the neuroanatomy inside the epidermis. To confirm this, we investigated with PCR and RNA sequencing the marker genes. And these are, for example, semaphorin 3A, nerve growth factor, and we found that they significantly correlated with the reduced nerve fiber density, and also nerve generation genes after injury correlated negatively with the density. That means the lower the nerve fiber densities, the more the genes are upregulated. And further, the gene expression correlated with the pruritus intensity and pruritus duration. And especially pruritus duration is of interest because the longer you have pruritus, the longer you scratch. Next to the structure, we could also show that these nerve fibers have an altered function. And either if we stimulate the patients with COAG, what is this chemical stimulus, or with electrical stimulation or with mechanical stimulation, we always saw differences between these 3 arms. And you see again here our gradient that the itch intensity is highest in those patients who have the most lichenification. So what contributes to this neuronal sensitization, so altered functions I just showed you? And here are only 2 examples, and here I connect to the talk Mette just held. We have the Th2 immune axis with IL-4, IL-13 and IL-31, and other inflammatory cells as eosinophils, which are very interesting because they are frequently defined closely to the nerve fibers and are also discussed to contribute to the sprouting. Interleukin 4, but also interleukin 13 in between, can sensitize our nerve fibers. So if a lot of interleukin 4 and interleukin 13 is in the skin, and in fact we know that in AD skin, especially IL-13 is highly upregulated, they bind here to their receptor, Mette showed us so nicely, and by that the capacity of the nerve fibers to react to the interleukins or to histamine is increased. So the nerve fiber more quickly and more intensively produces action potentials. This is called, at the end, neuronal sensitization or hypersensitivity of the nerve fiber. So what is the consequence for spinal mechanisms? This is not the map of the subway of Berlin, as you know. You use the subway every day. This is how we understand at the moment the transmission of the itch signals to the brain. And here we have itch generation, we have our itch fibers, our pain fibers, our touch fibers, and you see it's a very complex mechanism. We have here gastrin-releasing peptide and its receptor. And it was again Gill showing in monkey experiments when monkeys scratch up to that they have lichenification, there is an increased expression of the receptor of gastrin-release peptide. So there's the receptor in the spinal cord. And this is something what fascinates me, that by scratching the skin, we can influence not only the skin nerves, but also the spinal cord. Of course, this is animal. Of course, this is outside the skin. It goes to the brain, but I am here to bridge Mette and Gill and to give you insights into the nerves. And by that, I like to summary. So animals and humans are different. We have to be careful when we see their results from anatomical studies. We always must validate these findings in the human situation to understand better the itch generation in humans. But scratching has a huge impact on the nerve fiber anatomy that we should not underestimate. This changes their function, not only the structure, and the function is more important. And we need to understand how our current treatment invade in that. We have the idea now that dupilumab already restores some part of this neuroanatomy, and the micromilieu is also very important. The genes I showed you are mostly producing and releasing substances in the keratinocytes, influencing the nerve fiber function and structure. And by that, I want to thank you very much for your attention and take questions.
So if anybody in the audience has questions, Dr. Kawashima.
Sonia, nice presentation. So my question is, under the atopic dermatitis conditions, you mentioned peripheral nerve distribution is decreased. But at the same time, IL-31 and also NGF are increased in the skin lesion. So do you have any idea how peripheral nerve distribution is downregulated under atopic dermatitis conditions? Maybe I should ask the Jiro.
So here is an echo. So what I understood is NGF is upregulated in AD skin. That was frequently shown. And the question
is how peripheral nerve distribution is decreased in atopic dermatitis.
We saw also an increase of the NGF genes.
NGF.
We saw an increase of the branching. We think that the NGF has an influence on the nerve fiber branching. And when we refer to the decrease of the nerve fibers, we count them at the moment they cross the basement membrane. And maybe we don't have enough NGF levels exact at that moment when they invade the dermis. So I don't know about NGF expression in the dermis. Yeah, but in the epidermis we have high NGF, and there the fibers are branched.
And another question is, did you see the relationship between tight junction and peripheral nerve distribution? So in atopic dermatitis, peripheral nerve extend tight junction.
Did you understand? I have here such an echo.
Okay.
Yeah,
No, come here.
So,
We
no.
will
So what
clarify.
I suggest something. So the echo here is absolutely awful. Could you maybe approach the podium and ask your question, and then she can repeat it and answer?
Come here. We will discuss.
It's awful. I don't know. I hope that you hear the speakers well, because we can't hear anything.
By the way, do you have a talk? You guys just can continue. This is a famous guy also.
Sorry. So my question is whether peripheral nerve distribution is, so what is the relationship between peripheral nerve distribution and tight junction? in atopic dermatitis?
Wow, yeah. Yeah, a very, very good question. We saw that the tight junctions, Mette showed this very nicely, that the tight junctions are altered, yes? And so, because the nerve fibers, they have to go through these keratinocytes, there might be really a relationship. However, this is in the upper levels of the epidermis. And we saw that some nerve fibers in atopic dermatitis, I showed you that the branching pattern is mostly linear, and we saw that they start to branch in the upper levels. We did not investigate if this has something to do with the tight junctions. It would be a very good idea to consider that. Thanks, Kenji.
I have a question. So this was really a fascinating presentation, and I was looking at all these differences in terms of nerve fibers and branching, and I was wondering if you're aware of anything that is currently in our medical therapeutic armamentarium that can have an effect on nerve fibers or branching. That's like first part of the question. And the second one, do you know of any companies that are working maybe on developing drugs that could have an effect on that?
Yes, this was my hope. There was a company, Sienna, that had a topical Gil-help-me-track antagonist, like an influencing the NGF expression and also the CHIP-V1. So this could really would have had an influence on that. But unfortunately, they were in the psoriasis program. They stopped it. And so, to my knowledge, there is no company. Maybe Gil knows more.
No, I don't know, but I can tell you why I recommend the company not to do an atopic eczema, because we actually looked at NGF. I have to mention, historically, the Japanese, in about 20 years ago, reported that NGF levels in atopic correlate significantly to itch, which made sense because the idea was, and there are a lot of Japanese studies showing that more nerves in mice, more itch. Makes sense. And interestingly, we did what we call a skin microdialysis study. It was actually one of the most cumbersome studies for patients as well as doctors, because we had to be hours measuring. Microdialysis measures basically what is going in and out into the skin. We found actually the levels were significantly lower. And I don't think that NGF has a significant role, and therefore blocking NGF didn't really work. So I would deviate away from targeting NGF.
And did you do the microdialysis in the epidermis?
No, in the upper layers. It can't be in the epidermis. You have to have it in the upper dermal-epidermal junction.
Because this would somehow confirm that the NGF is not relevant in the dermis,
yeah.
And there we don't have the sprouting. It's very interesting.
But I still don't think that, you know, the fact with the TRK in psoriasis, by the way, NGF has a more role in itch. But by the way, I think the science evolves, and I just don't feel that NGF, this is my take, Sonia, that NGF is really a target in terms of the itch of atopic eczema.
I remember there was also once a company, I don't have the name, who had a topical NGF antagonist, not
Yeah.
TRK, but this is long ago, and they also are not around anymore. Regina, you have a question?
Yes. Thank you for your nice presentation. It was excellent. I think all the talks on AD reflect that it is very, very complex. And now my question makes it more complex. Are there studies showing an association between microbiome and numbers of nerves?
There are no studies for the intraepidermal nerve fibers, but there are studies that support the hypothesis that the nerve fibers are more sensitized and that this level of sensitization also reaches the spinal cord. Yeah, and there the AHH receptor is involved. This is the receptor for pollution, where pollution is transmitted. And this receptor, you know, when pollution binds to this receptor, there's a release of arginine, and that sensitizes the nerve fibers. And there's some studies arguing also for microbiome doing the same. So we are not microbiome researchers. This is very, very complex. Gil might do it. He published something on the microbiome recently on prurigo patients, and he has also the capacity to do nerve fiber staining, so maybe this is a good idea for him. I see he's already thinking about that.
Oh, no, it's an excellent question. And indeed, the nerves work very well with the microbiome. There's a lot of ongoing things. We actually try to do that in that study. It wasn't so clear. What we could say is that the activation of proteases, the proteases that are activating itch are highly expressed, and they do correlate with this microbiome. So it won't surprise me with atopics. You would find more interactions with nerves. I don't know, I think I saw Brian Kim there at the end. He's chairing a very interesting session in 3 weeks' time. There is a world conference of it, so I'm promoting it, but it's too late. But basically, he's bringing some really outstanding neuroimmunologists that their expertise is really that cytokines in pain, because in pain, there's understanding. One is Isaac Chu and another is Sokol. Right, Brian? I'm getting old, don't remember the names well, but I think this is an area where we'll know a lot better, and I'm looking forward to, and not me, just all our society and the scientists will answer your excellent question.
Thank you very much.
So, thank you all.
I have just one more question, because we work, it's interesting because we were working so many years and very similar understanding, but I didn't hear, what's your take about, I heard about scratching, but what's your take about the lack of nerve fibers in lichenified plaques, which is lower than in healthy? What's your explanation? I have my hypothesis, you may know, but I didn't hear yours.
Yeah, this is why we are working on the molecular factors that contribute to the injury of the nerve fibers. We think it's transmitted via the keratinocytes, that they release some substances that destroy the nerve fiber in itself. So for that we have produced scratching machines in my lab, and they put keratinocytes, and really the whole day they are not my biologists, they don't have to scratch it, so we have an automat, and so they go into the molecular mechanisms, and together with the company Galderma, who has an interest in prurigo, we also investigate currently fibroblasts that are very important in the pathogenesis of prurigo nodularis, and there also seem to be very interesting signals by the mechanical stimuli. So this produces stress, actin filaments. This is what is all very well known, but we go beyond that to find the molecular mechanisms. I don't hear any counter-arguments, so Gil seems to be happy, and Robert is also happy, so shall we go into the break, or?
I'm very happy because we're ahead, and I know many of you have either flights or trains to take. So my proposal is we have a 15-minute break in the agenda, but maybe we can do 10? Like bio break and come back in 10?
Yeah.
Anybody who disagrees? 10-minute break.
10. 5 past half. 5 past half.
3:35, we're back.
35.
Itch and microbiome.
I wrote also an topic with the Chinese guy, very also itch, microbiome, but these are the two because her figures are so good. She's a whiz, we looked at the neuropathy. Your questions are very good. I mean, it's clear that there's. She kind of covers all.
Many of your talks.
Yeah. Wow.
Very good.
We'll see. I don't know. So,
Yes, I know.
And is there a link? That's the road microbiome. The same microbiome is just their link, journal clinical medicine.
Kim.
Yeah, that's not a real. Every Korean is.
Yeah.
there. We'll have a nice week with some other.
Sonia was supposed to present you, but I think I'll do it. I'll do it because I'm not back.
Yeah, ladies and gentlemen, now it's my honor and pleasure to introduce Gil Josipovic. He has an itch center in Miami, and he is in fact the founder of the International Forum for the Study of Itch. And Gil, you did so much and groundbreaking work in itch. I think you don't need an introduction. And you were the first to do central nervous system studies with fMRI, and we ask you today to give us insight into that. Thank you, Gil.
Thank you, Sonia. It's such a pleasure to be here, and I know it's kind of at the end of a meeting, but I hope I'll still interest you in this amazing session that Robert and you are directing. So I have a lot of disclosures, but today I'm not going to speak about most of the drugs because I think that we'll explore the brain. And here we don't have specific drugs yet, but possibly I'll try to demonstrate to you that there is a potential here. So I'll discuss a bit brain neural mechanisms of itch, discuss a bit the neural sensitization. We saw that there is something in the nerves today beautifully with Sonia's work, and then some psychological aspect. Don't forget that these patients of atopic dermatitis have a lot of psychological issues, and I hope that you'll understand why brain imaging does help and what should we target in the brain. And the question is really, what causes itch? So all of you are in atopic eczema are very familiar with all the cytokines and the chemokines, but also remember there are physiological factors like sweat in atopic eczema. It's a very interesting area, but there's also central brain activations. That's what I'll share with you. I mean, there are emotional aspects, and clearly stress. Actually, Kenji, his group did work on stress in Japanese, and stress and itch go together. And then there's also inflammatory components of nerves. Sonia alluded a bit about NGF and Artemin, but there's also abnormal innervation. She already discussed about that, but there's a lot of other central mechanisms that are related. Sleep is centrally mediated, as you know. So I think we sometimes forget that what is the component of itch, and in terms of, you know, the itch emanates from the epidermis and upper dermal epidermal junction, but the neural transmission of itch goes into the spinal cord and up to the brain. And clearly there's also some aspects of downregulation of the itch perception. So to me, and I had once a very interesting, remember Sonia with ESDR, I think we had that cookbook, we had what was it called?
Kitchen, the ESDR
kitchen. Yeah, about the argument, yeah, about how to kind of interact brain versus peripheral. Is itch mainly peripheral or is it central? So the idea here is that I'll try to persuade you that there's significant central mechanisms associated with itch, and I have to mention that we've looked at some of these issues. I'm not a psychologist, but I did work with some psychologists, and clearly there's a lot of effects in the brain that can reduce the itching of atopic eczema, such as attention, catastrophizing these patients, anxiety, stress, depression. And there are some also individual differences in perception. But I like this really nice figure that my colleague Ethan Lerner's had drawn for one of the journals, is the yin and yang. I added the yin and yang of itch, but he wanted to demonstrate that this vicious circle of itch scratch cycle. So in order to scratch, you need a brain. You can't just do it spontaneously without a brain. And clearly, in order to get the itch perception, you need that nerve. One first question is there actually an itch center in the brain? And this we actually looked at. We did fMRI studies using, at the time, a new technology called arteriospin labeling. And we imaged both the non-histaminergic and histaminergic. And you all know that histamine doesn't really have a significant role in atopic eczema itch. But CowH, which activates part 2, which is a highly associated with atopic eczema, we could differentiate areas in the brain. There are a lot of commonalities, but if you could see here, what you could see here is that with CowH, there's a lot more extensive brain activation versus only with histamine. But I want to mention that there isn't just one, I wish there would be, but everything is more complex. There are a lot of areas that are highly activated, but they do interact, and that's one of the questions that we've been interested in, to understand how these sensory, thalamic, limbic, stress-related are associated, and also there's a motor component because the scratching is a motor activity. So the question now is there really any difference? Because these are physiological studies, but I'm interested to know whether there is any difference in atopic and healthy. And in this study, my colleague, he was my fellow, Yozo Ishijo from Japan, spent time with me and did fMRI studies of atopic dermatitis versus healthy control. And indeed, when you induce itch, there was a significant difference. And I won't cover so many sites, but I'll tell you what the highlights of it. First of all, there was significant increased activity in the insular cortex. I know this is not, it's dermatologists, the majority of, but still, it's important to understand this is anatomy, neuroanatomy, I think, first year of medical school. The insular cortex has a lot of aspects of awareness, sensations, feeling, pain, warm, and also itch. And then we found also that the ACC and PCC, anterior cingulate cortex, posterior cingulate cortex, are highly activated in atopics. They very highly associated with affective dimension of itch. And the posterior cingulate cortex has a lot of memory and emotion. And I'll get to that. You'll see later on why is it so important. One of our findings, and we've continuously seen it in different studies later, is there is an area of it in pain, so there's a lot of similarities with pain areas. But the precuneus, which is part of a PCC, is actually deactivated in pain. So here's the difference. We don't know enough, but we feel that this is inducing memory retrieval of itch. And you'll get to understand better later on why it's so important. And second is, I think Sonia alluded a bit, that neurosensitization. So this is in the periphery, but there's spinal as well as central mechanisms of hyperactivity of brain in areas that are known to be associated with neurosensitivity of pain. And this is a phenomena that all of us actually experience in daily life with our atopic. So this shows to you a patient who is scratching, and basically in a patient with atopic eczema, there's a lot of component of scratching. The idea is that the scratching, although it relieves itch temporarily, it actually activates the nerve fibers, and it's a lot of central mechanism. It's the The term is alonesis, and this is why when a patient of yours tells you, I put a sweater, or there are changes in the temperature, and I get more itch or get itch, and it doesn't happen to a healthy subject, that's why, because the neural system is overactivated. So alonesis is a non-itchy stimuli causing itch, and hypernesis is a itch stimuli that is mild, that is amplified in this patient. So this is all neurosensitization. And indeed, this is a study by Dr. Yelde Anderson, who was sent to me by the world expert of pain, a Danish guy from Aarhus, Mette, that he wanted to study itch. He was an expert in pain, and we did a study on neurosensitization of atopic dermatitis. And what he did is mechanically evoked itch. And what you could see here is that the atopics, both in lesional skin and in non-lesional skin, also have a significant sensitivity and amplification of itch, because this is actually that phenomena that we reported. So I think it's clear that there's neural mechanism of neural sensitization that are centrally evoked. And indeed here, Dr. Yoshijo also did some studies on the imaging, and in terms of atopic eczema, the areas that are highly activated beyond what I mentioned to you were associated also with intensity, and they're the same areas that are known to be activated in neurosensitization phenomena, like cases of fibromyalgia or patients who have chronic pain with unexplained area, and particularly the dorsolateral prefrontal cortex, ACC and PCC, as well as the insula. So here I want to explain, yes, I'm a big proponent of all these drugs working on inflammation in the skin. But do remember that targeting the brain may reduce a bit the scratching and may reduce also the neurosensitization. And we've done studies, these are studies not from mine, in 1994, Gupta, a Canadian, he's a dermatologist, but did a lot of work at the time and showed that there is a change in in atopic dermatitis and also in psoriasis. There's an increase of itch with stress. I want to mention stress because stress is basically a strong component of all our lives, unfortunately, but in atopics, there's a significant impact on their condition, and clearly it affects the stress. And this is a study that Hideki Moshizuki from my group published 2-3 years ago, where we looked at atopic dermatitis patients and looked at their hypothalamus. Hypothalamus is the center of stress in the brain, and interestingly, he looked at anatomical. This is kind of interesting because you'll see something that kind of coincides with a peripheral. The amount of gray matter, which is suggestive of less nerves, was significantly reduced in atopic dermatitis, and clearly highly correlated. What you could see here is in healthy, it correlates, but in atopic dermatitis, the opposite happens, is that there's a high negative correlation. The more stress there was in the stress score, the less volume of hypothalamus. And this is like a bit crazy, but now we can understand that even we saw in the periphery, there's anatomical changes. Because I can tell you, when I was a medical student, I learned that you can't have any changes in the brain, only it decays. We're getting older and the brain loses its volume. But now we know that actually the volume of the nerve the gray matter, which is reflective of how many neurons are, is going lower in atopic dermatitis. And I want to show something else. This is another study that Dr. Moshizuki did with our team, is how stress aggravate chronic itch. So we kind of summoned healthy subjects to do acute stress. So there are two components, acute stress and chronic stress. And what you could see here is that it's very interesting. So our hypothesis was that most probably there'll be more acute stress in atopics, there'll be more itching. Interestingly, no. Actually, it was less than but in patients, this was actually the scratching I'll show you in a second. So the itch sensitivity was reduced in AD. Patients after acute stress had a significant reduction in their itch perception in acute stress. However, when you look at their scratching behavior, we had a video implemented. They didn't know that they're also recorded with a video. They were told to give a talk about what they want to do in life or something, and then also to distract the number from 1,997. It's not so easy to do. But you could see the patient had significant activation of scratching while their itch perception actually was lower, which is interesting. So to summarize, chronic AD itch can affect both function and structures in the brain. But now the question is, what about the scratching? And clearly, scratching is a strong component of a chronic AD atopic itch. And it has also some rewarding effects. So we wanted to understand why is it so rewarding? And first of all, just to let you know, we always use in our assessment tool scratching pleasurability. And we've published that in the majority of chronic itchy patients, but atopic stand out as number one. There's also lichen simplex chronicus that the pleasurability of scratching an itch in atopics is number one. It's just unbelievable how, if you ask them, they'll say, oh, it's sometimes, that's amazing pleasure. We know that it's not good, but it's not something you can tell them to stop. But there is a correlation between the intensity of the itch, very strong correlation of these patients, and the pleasurability of scratching. So the question we had, are there any differences in scratching processing between chronic AD patients and healthy subjects? And indeed there is. There's a higher activity during scratching in the motor areas and also in motivation. The areas this shows you the major activations, but the idea here is there's a lot of activation in the reward system. And I don't want to, I want to be careful in this interpretation, but it does kind of remind you of people scratching. And that's why I say it's horrible to tell these patients, stop scratching. It's so addictive. And it activates several of the areas of a reward system that's what drug addicts do. So I would say that we do believe, and what we showed was in basal ganglia, that's the area where dopamine significantly increases. So we do believe that this is another area in the future, at least, that if you could attenuate activity, it will reduce the itching. We actually did a very interesting study, but unfortunately, it's a long story, but the FDA stopped. It's a long story to start with. We did cowhage in Parkinson patients because we had this observation that Parkinson patients don't actually like scratching because what happens is that they have less dopamine. So we started that, then another time I can discuss that. But contagious itch is another component, and I think all of you, when we talk about itch, have that feeling sometimes, or see someone else scratching, feel that urge to scratch and itch. And in fact, we wanted to see whether patients with atopic eczema are more susceptible to visual cues. And I showed you a lot of the brain areas are involved in visual memory, spatial and visual. And indeed, we gave them saline, we showed them pictures of atopics itching versus sitting ideal, kind of. And we induced itch, so-called. We told them, we're giving you an itch stimuli. It was actually saline. And what you could see here, healthy do have a response, but look how amplified the response is in atopic eczema. So clearly they have activation of this contagious itch more. And second, we had, again, this camera. This is my fellow at the time, Dr. Papoy. In that computer that we were they didn't know that we're recording their scratching. So it sounds like a fun work, but it's, I think, hours of assessing videos and of camera we had to kind of implement. And what you see here is that the atopic scratch way beyond the areas in terms of amount of scratching and duration, seeing these videos of people scratching, even getting saline. So clearly there's a central mechanism of activation that atopics are more susceptible. And later on, a German psychologist who is really a wonderful person with Sonia also know, wanted to come in and work with us, and she actually, and she did the study that was asking for is, let's see what areas in the brain in atopics are activated by this contagious stimuli. And in fact, again, the striatum, the reward, was highly expressed. There also the somatosensory, the SMA, the orbital frontal cortex and the SMA, that supplementary motor area, again, kind of activating an area where scratching is. And basically, it's interesting because in Healthy, a colleague of ours, a psychologist in neuroscience, published in PNAS that not these areas, but these were in Healthy. And I still think that, and he was stating that this contagious itch is related to a neurotic behavior, and he found in the cortical area that is that area activated by contagious itch. But in atopic, it's clearly the areas that are reward, striatum, and the orbital frontal cortex. So again, issues that brain, skin, and itch. And the question is now, we're in this era, I'm so excited, look how many drugs we have. We have so many new drugs. We have, I'm not gonna be promoting all the drug companies, but we have so many interesting things going on. Since Dupi, Trelo, nemolizumab, which is a amazing anti-cytokine drug, but it goes on, and we'll have OX40 and JAK inhibitors that are extremely powerful. So Dupi really opened our field, and we're continuing. I mean, Robert will give us, I'm sure, a very comprehensive talk about that. But so the question, maybe I don't need to be standing in this podium and talking about what to do with the itch. However, my answer to you guys is no. We have excellent treatments, but there's still patients who suffer from itch, and the meds reduce inflammation extremely well, but they are not covering all the aspects of this itch. So question is there any potential therapy targeting the brain? And my answer is a bit more complex. There are kappa opioids. We know that kappa opioids, these are nice studies actually from Japan emanating, that there is an imbalance between mu and kappa opioids, and that led to development of a first drug that is in the Japanese market, nalbuphine. Now we have in the US difelkefalin, given for chronic kidney disease, itch, and dialysis. But we've, for almost 20 years, using a drug, off-label use of butorphanol. It's a kappa opioid and a mu antagonist. And we actually did the first MRI study, whoops, I'm jumping too much. So we did the first MRI study looking at pharmacology using fMRI effect on the brain. And indeed, butorphanol totally inhibited itch, stimuli of itch. It didn't totally eliminate the cow itch, unfortunately, but it did reduce it. But we showed that the inhibition was paralleled by activation of, again, areas that are related to nucleus accumbens and septal nuclei, again, areas associated with reward systems. So clearly drugs can work on the brain to reduce itch. Now, I'm going to throw on you a bit new concepts that I am just in the process of better understanding, but there's a long way to go. Is I strongly believe that glial cells have a role in itch in the brain. This is not work that we've done. This is Japanese researchers, some Chinese, looking at possibility of understanding glial cells in the spinal cord, and it could be also in the brain, inducing itch activity. However, on a practical level, what we, and this is less scientific, it's just that for the last couple of years, I have used drugs that have some effect on glial inflammation. They're very potent antioxidants. So some of you are familiar with N-acetylcysteine. It's been actually reported for repetitive scratching in obsessive compulsive disorders. And then flavonoids like quercetin and bromelain also have been shown in mice models to reduce itch significantly and also affect glial cells. So I think it's worth to explore these. You buy them over the counter at the moment in health shops, but it would be interesting to look at. And last and not least is, although I'm a big proponent of drugs, as I believe that they work extremely well, but I do believe we have to be holistically treating these patients and beyond pills. And these somatosensory aspects of pruritus have emotional components, and clearly we need to try to address them. And indeed, when Christina was in our place, I was amazed. She trained some of our very severe itchy patients with atopic dermatitis in techniques of deep muscle relaxation, and indeed it reduced itch. You have to be susceptible to that. If a patient tells you, I don't want to do any, I don't believe in any holistic approach, it's not worth your time. But it doesn't require hours. Basically, it was 10 minutes twice a day of exercise. And indeed, I had some patients with excellent results. It later also led to some a brain imaging study that she looked again on the neuroanatomy. Unfortunately, she didn't finish that, but we showed that there's actually an increase in gray matter. So hopefully we'll continue doing that in the future. It's not, usually these are drug trials, they're not drug trials, so we don't have funding and they're expensive, but I believe that there is a role for it. So what are the challenges of treating chronic ADH on the level of the brain is, and this is the questions that I have that I think we would be able in the future maybe to address, is why there's such a variability in itch perception. When you have the same severity of eczema, I have sometimes patients who have just one area specifically that drives them nuts, and then you have a retrodermic, almost atopic, and he says, well, I have my itch 5 out of 10. And then, why is there such a variability in treatment response in terms of itch? And my question to you is, to raise your kind of awareness, is would a drug that targets the brain be effective for all AD itch patients? I don't have an answer. So in the conclusion is, there won't be one drug to provide a quick fix for all itch for AD patients. So those in the pharma who want to continue developing drugs, I encourage you. 2, targeting the brain and CNS drugs, including holistic approach. I hope that I convince you that there is a rationale to do that. And I believe that central neuroinflammation is an exciting area to explore, including in atopic dermatitis. So I thank a lot of the collaborators, include my colleague Sonia Standard, who for years we're working together, a lot of my former fellows, a lot of people from all over the world, and it's just a pleasure working with them. I later on learned from them, and it's just very interesting because we kind of explore that together, and I encourage those of you who, it's a bit too late now in the game, but I think that the World Conference of Itch will have a lot more information about what's going on new in itch. So I thank you again and open for any questions.
Any questions for Dr. Josipovic? I can start by one. So a very interesting lecture about the reward pleasure aspect of scratching in atopic patients. And I was wondering, We now have a number of systemic drugs that we use in our severe atopic dermatitis patients. And every once in a while, at least I in my practice, have patients who respond fairly well. The inflammation seems to be under control. They're heavily lichenified. And even a year or two after treatment, they stay lichenified. I'm under the impression that I control the inflammation, but not the lichenification aspect. Some are still, itchy, but other patients are as itchy, but they don't, stay lichenified. Do you know if anybody looked at these patients? Would these patients be those who are scratching, not maybe because it's so itchy, but because of the reward pleasure aspect of it, that maybe I should, send them to a behavioral therapist as opposed to changing treatment?
Yeah, excellent question. I don't know. I'll tell you what I try to do. I'm sharing with you. This is kind of, I wish I could do that. So when I was at Temple way back, there was a world expert in imaging in the Department of Economy. Who do you think? Chronic gamblers. So I said, let's see them if they enjoy scratching like atopics. Opposite direction, but to try to understand that. So we're about to do that study, and then I left, and no collaboration. But who knows? Sonia, isn't it? I do believe that there could be a common denominator. Don't misunderstand. I don't want you to go and then say, oh, atopic eczema are like they're... I think my message is, when you have that chronicity and you activate the brain, don't be surprised that the neurosensitization affect that reward system and it amplifies it. It doesn't mean that treat them, because the worst thing I think I find with my patients is they come and they tell me, people told me stop scratching, but they can't do it. I mean, when I have an insect bite, I can't do it. And I'm telling you, doctors, I have to be careful because they're Americans. I come one day to New York to this Manhattan Derm Society, and someone says, you have a really nice talk, but you didn't mention what you need to do in all your patients. I tell all my patients, stop the heck of scratching. And I was like looking. So these are dermatologists who are telling me that they could convince their patient to stop scratching. What can I say? Okay.
Gil, I like to hear your take on contagious itch in schools, where whole school classes start to itch and to scratch. They don't have permanent activation of the reward system. So what is their reward? And you did some great studies with Christina. So what is your take on that?
Yeah. So here, there is what we call mirror neurons. So that was initially what we thought. What is mirror neurons? All of you know, when I will start yawning, most probably half of the audience will start yawning too. That's actually a contagious activity. That's why we also looked at monkeys. I think you mentioned that we thought that actually the same area would be activated in atopics, but we didn't find that. So clearly, I think in atopics, the mechanism is a bit different from yawning but there are visual cues. And if you remember, I showed you some of the areas in the brain, the orbital frontal cortex. These are areas, or even the precuneus, they're involved in visual, at a kind of restructuring of visual and memory. So clearly, that's where I believe, I don't know, there's a pediatric derm, I think that initially, if you see the babies, they don't scratch themselves, but they learn later on the brain. They itch, but the way they itch is they use their body movements. And I think that during the process of getting older, the brain gets more developed, and part of that reward system they learn by seeing others, and it's more complex. I'm not a expert in, how's it called, sociology of evolution of behaviors, but I won't be surprised, but part of it is our brain starts to memorize, oh, this is an activity that we need to continue doing. Okay. Any other additional? Yes.
I
just wanted to share with you and maybe pick up your brain and your ideas. We know that Th1 cytokines usually impact they facilitate the sleep, right? In contrary to Th2 cytokines that they disturb sleep and circadian rhythm. So what do you think, what is your opinion about scratch-independent disturbance on sleep in AD patients?
Yeah, it's very interesting and very complex. So I'll tell you, I worked a lot on my previous hat. I did a lot of skin physiology, so I don't know if you know, I actually published the first time circadian rhythms in the skin. It's my first JID paper, so I do remember it, 1998. And clearly, you know, the circadian rhythms are also abnormal, and basically in atopics that I'm not aware on the brain that they did that, but it wouldn't surprise me that, again, the issue is amplified with a lack of sleep, and there is an abnormal circadian rhythm, there is an abnormal, I didn't discuss today, we did some interesting study on autonomic nervous system. They have like a almost sympathectomy-like, very interesting with overexpression of parasite. There's some mechanisms that we don't know exactly what's going on there, but it's clearly important to understand. Another issue about the circadian rhythm that is more peripheral, it's less maybe central, is that we found that the temperature of the skin goes up by 1 degree at nighttime. And that's a key factor. If you know about nerve fibers, C nerve fibers, that's what we're looking at. The C nerve fibers are very sensitive to heat, and it activates, these are the same C nerve fibers that transmit itch. So the fact that the skin temperature goes by 1 degree Celsius is a major issue of activating that itch scratch cycle. Hopefully, please.
Very interesting, because we've been hearing that the patients who receive, for example, dupilumab, and with tremendous improvement on itch, and when you ask them the question, how do you sleep? And they still cannot sleep, even though they don't scratch during the night. Mm-hmm. So that was...
I think the neural system, I mean, my impression is there's a significant improvement in sleep in all the biologics that work, that reduce itch. But it sometimes could do, you know, as I mentioned, the amplified, there could be a lag sometimes in terms of the sleep deprivation and how to recover. I have to tell you, I've played around with a lot of sleep additive like, you know, melatonin. I'm not impressed that that's the venue to go to, but I think that we would know better, but it goes to brain mechanisms for sure of stress, lack of sleep, activating a vicious circle, and these drugs, when they reduce that vicious itch circle, clearly it will help the sleep.
All right, only 2 talks to go. So I will be talking about the antipruritic effects of biologics, small molecules, and topical treatments for atopic dermatitis. I don't know where there's a 22 there. So this is my disclosure. I'll be talking a lot, obviously, today about drugs, and I have conflicts with most of the drugs I'll be talking about. I either served as a consultant for the pharma or biotech, or an investigator, or managed studies for these companies. So let's start by a very important information about itch. So this is a survey, a patient survey that was presented at the RAD meeting last December and should be published soon. And what the patients were surveyed about was, what's the main driver for requesting a change of medication when you see your physician? And the number one by far was itch. So itch was more than double in terms of the most important reasons why. The other ones were side effects, skin redness, dry skin. So patients are really concerned about itch, and that's the number one reason why they come to us and say, oh, I would like to try something different. So we need to manage itch. So I decided, as you know, we have a number of new drugs that have been approved for atopic dermatitis in the past 5 years. We have many drugs that have undergone phase 3 and for which the data is available. And we have even more drugs that have been studied in phase 2 or even in phase 1. So I could not talk about all those drugs because it would be just one slide after another of itch data. So what I decided to do is I decided to focus on drugs that are approved and drugs for which we have phase 3 data. There are other very interesting drugs in phase 2. Let's wait for the phase 3 data. The other thing that I did is I focused my presentation a little bit more on the topical drugs. I assume that most people in the audience are more from Europe than North America, specifically on Saturday afternoon. And you've been maybe less exposed to some of that data. You probably do not have most of these drugs in your therapeutic armamentarium because they've been approved mostly in the US, Canada. In addition, a lot of that new data and new data about itch has been presented very recently. So let's talk first about choosing to treat patients with topical or systemic. So patients with atopic dermatitis and patients that are specifically very itchy. So how do we do this? As a dermatologist for a very long time, what I used to do is I would look at the patient and I would evaluate the body surface area. If it was 1 or 2%, I would think topical. If it was 50%, I would think systemic. And my cutoff point was often around the cutoff point of trials for biologics and atopic dermatitis or oral drugs and atopic dermatitis. I'll show you data today that I think will have you think twice about that strategy. I don't think it's the ideal strategy anymore. I've used some of the new topicals in patients who were covered with atopic dermatitis with very impressive response, and I think that when those drugs will be more available and approved for AD, I think we should envision treating some of our patients that we would automatically label as systemic with these topical drugs. This being said, patient's preference is extremely important. Some patients do not want topicals, they want a systemic drug. And other patients, they do not want any systemic, they want topicals. And to completely go against patients, I've learned with time that you usually don't win. Stable versus recurrent flares. So this is something I think we should always ask our patients that we don't know, so new patients that are referred to us with a significant amount of atopic dermatitis with a high EZ and a high BSA. I think it's important to understand if they're almost or approximately the severe, or if they have 2-3 flares per year, and usually they're down to a few percent. If they have a few flares per year, they might be patients for whom we should think about controlling those flares with topical drugs. Previous response to topical and systemic treatment and itch location are also important. Now, let's talk about the topical drugs for pruritus. The first drug I'll talk about is topical ruxolitinib. So this is currently approved in the US. It's a JAK inhibitor. It's approved in patients with BSA of 3 to 20%. And was studied in patients with mild to moderate AD. So this is important to notice because the topical drugs were not studied in the same population. This one had a cap at 20%. So on the left, you see the efficacy on atopic dermatitis in terms of patients achieving IGA 0/1 with a 2-grade decrease. The drug concentration that is approved is in blue, is the 1.5% concentration, so 53.8% versus 15, 51.3 versus 7.6, obviously highly statistically significant. Today, the focus is on pruritus, so look at what's on the right side of the slide. So what you see on the right slide is that, let's see if it works. Yeah, it works. So what you see on the right slide is that the onset of action on pruritus is super fast. As early as 1 day after treatment initiation, there's a difference in terms of pruritus between patients randomized to vehicle and patients randomized to active, and this is statistically significant. So in both trials, it was statistically significant, and you see that most of the improvement in pruritus is observed within 7 days. So the onset of action is very fast. Now, I'll show you, oops, nope. Yes. So I'll show you data of another study that we managed and we completed at our center in Montreal. This was an Insight-sponsored study. In this study, what we did is we recruited patients with atopic dermatitis. We've applied ruxolitinib, and we looked at pruritus NRS at 15 minutes, 30 minutes, an hour, 2 hour, 4, 6, and 12. The 12-hour time point was done at home. And what we found was, as early as 15 minutes, the improvement of pruritus was really significant. So within 6 hours, more than 50% of the improvement that patients get is there within 6 hours of topical application. And you see the difference at 15 minutes. So now I'll show you some data of off-label use of ruxolitinib. So remember that I spoke about treating patients with significantly high body surface area with topicals. So this is a study that was done in patients with more than 25% BSA. So it is off-label because this drug tends to penetrate, and when you treat high BSA, then you can have drug concentrations that are high and detectable. And I'll show you data around that. So in this study, what we did was, for the first month, we treated patients twice a day on all lesions that were present at baseline. And then after a month, patients who were clear were told to stop treatment, and patients who had some residual lesions were told to apply the drug only in residual areas. So in terms of drug levels, what you see on the right is in green, you see drug levels of oral ruxolitinib. In blue, you see the mean drug level for patients that were treated. On the left, you see drug levels over time. You see them going down. However, in 2 patients with very high BSA, so 45% and 90%, we did observe those levels that were close to the drug levels that you see when you treat patients with oral ruxolitinib. Again, going in the direction of what people have observed in the past, that you have penetration with this drug. What was really fascinating, and I was really impressed when I did that study, was that when you look at day 28, so after a month of applying it twice a day, you have about 60% of patients who are clear or almost clear. So these are patients with 25% BSA or more, 60% clear or almost clear. Now you stop the drug, or you tell them to only apply it on residual lesions. What I would have expected, based on my experience with TCS, would be that a month later, the control would go down. But it's not the case. The control goes up. And we have about 80% of patients now that are almost clear or clear. Now, we recently managed a study that had a very similar design, but that was done in kids. The previous study was adolescent and adults. So this study was done in children 2 to 12 years of age. And in this study, we also looked at itch. So what you see here is that when you treat children with topical ruxolitinib for a month, you see the itch going down from about 8 to about 1 to 2. And this is a maximum use study. These are, again, patients covered with atopic dermatitis. And when you stop or ask them only to use it on residual areas, you can maintain control of itch, more or less, for a month. What's very interesting about that study is, as opposed to the adult study, we also follow those kids for a period of a year. So we will have eventually, in the coming months, data in terms of itch control if you only apply it on residual area for periods as long as a year. So what's important to understand here is that patients start with a very high BSA, so they apply it off-label, then they reduce to less than 20% and can control themselves on-label with 20%. Roflumilast, so roflumilast is a PDE4 inhibitor. It's approved for COPD. There's a cream formulation that is approved in the US and Canada for the treatment of psoriasis. So those of you who practice in those countries, it's important to remember that the drug approved for psoriasis, the concentration is 0.3%, but the drug that has been studied in phase 3 for AD was 0.15. So what I will show you today are data with a 0.15 formulation. Now, this study was done in a different patient population. Again, mild, moderate in terms of IgA, but up to 100% total BSA for patient inclusion. This is the design of the study that was recently presented at AED as a late breaker. So you see randomization 2-to-1 to either roflumilast and vehicle. It was decided to have the primary endpoint at 4 weeks. The primary endpoint was VIGA AD success, as it is in most studies with topical drugs. What you see here in terms of clinical efficacy at week 4, 32% of patients had achieved AD success, as opposed to 15%, 28.9 as opposed to 12. This was statistically significant. When you look at itch, this is very interesting. I was surprised. I was pleased when I see this, I should say, and I was a little bit surprised, but not that much surprised. Why was I surprised? Because as a dermatologist, my view of drugs targeting PDE4 is that their onset of action is not super fast. If I look at the apremilast in psoriasis, if I look at crisaborole in atopic dermatitis, the onset of action is not super fast. However, what you see here is as early as 24 hours after you start roflumilast, you have a difference between vehicle and active, and this is statistically significant. So the onset of action on pruritus is very fast. Oops. Good. I'll go back. Great. And this is the WI-NRS success, so worst state NRS success decrease of 4 grade 201. So what we see is that at week 4, there's a statistically significant difference between roflumilast and vehicle in both clinical trials. Now I'll talk about tapinarof. So tapinarof is the third and almost the last agent I'll be talking about topically. So this is an AHR agonist. There's a cream formulation that is approved in the US for the treatment of psoriasis. If some of you are from China, this product is also available in China, but under a different name. It's known as benvitimod in China, and the formulation that is available is different. And it's approved for the treatment of psoriasis vulgaris. It's not approved yet for the treatment of AD. Phase 3 studies in atopic dermatitis were conducted again in a different population. They were conducted in patients with IgA of moderate to severe, so more severe patients based on IgA as compared to the other two drugs. And the BSA was 5 to 40. There was a cap at 40% in the 2 pivotal phase 3 trials. But this is a drug I know fairly well because I've been fortunate enough to do the first in-man study more than 10 years ago in Montreal. This is a Canadian discovery, in fact, that was taken over by a big pharma and finally by a US-based company. So for the first time at this meeting, the results were presented, and what you see here is the proportion of patients achieving an IgE 0/1 with a 2-grade decrease on the left. First study, 45.4% as compared to 13.9% on placebo. On vehicle, I should say. On the right, 46.4%, 18%, so fairly similar, highly statistically significant. So if we look at itch response, so patients achieving a 4-point decrease in peak pruritus NRS, 55% on tapinarof on the left, 34.2 vehicle, 52.8 versus 24.1, again, statistically significant. If we look at the onset of action, what you see here is the decrease in peak pruritus NRS. And what you see is that for the first study, for the Adoring 1 study, there was a statistically significant difference based on non-overlapping 95% confidence intervals as early as day 1. For the other study, it was at day 2 that we saw a statistically significant difference. The familast, so this is the agent I know the least because I've never worked with it. It's a PDE4 inhibitor. It's approved in Japan for the treatment of atopic dermatitis. It's in phase 3 in the US. So I'll be showing you data from the Japanese studies. Japanese studies don't report pruritus data the same way as North American studies. So they tend to report, as you see on the left, change from baseline in pruritus. In this case, it was verbal pruritus rating scale from 0 to 10. And it was a difference as early as week 1 between vehicle and active. So if you've not been listening so far, it's okay. But I would suggest that you listen now for maybe 15 seconds, because this is important. I think this is a very important message with those topical drugs. As a dermatologist, I know I cannot compare results from biologics and oral trials and atopic dermatitis between two different studies. It's scientifically incorrect. However, everybody tends to do that. You know, when they're published, you look at them and, oh, you know, it's 80% and now it's 60, and it must be a difference. And I would argue that it's not really a bad thing if the difference is big, because the inclusion-exclusion of trials done with systemic drugs in atopic dermatitis are fairly similar. It's almost always BSA-10, IGA-3+, and EZ-16+. However, with the topical drugs, as I've shown you, it's completely different. With some, it's mild to moderate. With others, it's moderate to severe. Some had a cap at 20. Others went up to 100. And you understand that when you ask a patient to apply medication on 100% BSA, what we often see in clinical trials and in practice is they don't apply it everywhere. They miss a spot, they can't reach the back, so you cannot compare. So don't compare. Look at it and make your own decision on how you want to use it, but don't compare the efficacy between studies. All right, systemic agents, I'll go a little faster here because you're probably well aware of all this data. Most of it has been presented a little while ago. I'll start by the first new drug that was approved for atopic dermatitis, dupilumab. At that time, the pruritus NRS was reported mostly by change from baseline. So you see the change from baseline comparing placebo to dupilumab. We see that as early as week 1, there's a difference, and we see the difference over time. One of the things that I've done on these studies, you may have noticed, is I put the baseline pruritus, because even though these studies were conducted in patients that were fairly similar in terms of inclusion-exclusion, we have seen over time a drift in terms of severity. So the most recent studies, and they were studies presented yesterday at the late-breaking session, we saw this as well, patients that are treated nowadays, on average, tend to be a little less severe than patients that were put in studies 10 years ago. Because most of the super severe, we probably already have them on systemic drugs. So I put the median mean baseline pruritus NRS. So lebrikizumab, phase 3 studies, change from baseline in the peak pruritus NRS. Again, same type of curves. The axes are a little bit different, so it doesn't look as nice as the other one, but it's because of the axes. 15%. 45%, 9%, 36%, obviously statistically significant. Here they looked at week 2 and saw the difference at week 2. Now, this I think is really interesting, and I would like to see more of that, because a change from baseline in pruritus is nice to try to see how fast the drug is, but what I'm really interested in as a clinician is what's the proportion of patients who really have itch under control? Now, I've had some exchanges with itch experts recently. I don't think we have a clear definition of what this is, but to me, a patient who has a itch NRS of 0 or 1 is somebody who has itch under control. In my practice, this is what I see. When they say 1, usually they sleep well, and it's not a big issue. So more and more companies are reporting this. The problem is that they're not really reporting it exactly the same way. They're not analyzing it the same way. And it's often not very clear when you look at publication how this was done or analyzed. So I think there's a need here maybe for a group of dermatologists to sit down together and maybe establish what should be done so that companies do the same thing on all trials. Regardless of this, in these studies conducted with lebrikizumab, we see that 22.5% of patients in the first trial and 19.9% in the second had pruritus NRS a score of 0, 1, which is interesting at week 16. Tralokinumab reported data a little differently. It reported it in terms of improvement over time, and you see that improvement over time comparing active and placebo, and in both trials, it was statistically significant. baricitinib. So I don't have the opportunity to be able to prescribe this in Canada because it's not approved. I did the studies, however, and in Canada we were limited to use the 1 and the 2 milligrams, and the results were maybe a little bit of a disappointment with the low dose. It's better with the higher dose of 4 milligrams that people in Europe can prescribe. Baseline NRS 6.1, 6.8, 21.5% of patients had a 4-grade decrease in pruritus NRS as opposed to 18.7, different than placebo. Again, a presentation of patients with the proportion of patients with a pruritus NRS less than 1.5. So again, this means control. Might not have been done exactly the same way as what I presented before, but this to me means control. And you see 14% of patients had control with 4 milligram as compared to 4% on placebo. This was statistically significant. Abrocitinib. So what's nice about abrocitinib is that they showed early data in terms of onset of action of pruritus. The earlier agents often did not look at the first days, but with abrocitinib we see this, and we see that very early on, after a day or two, we see a difference between placebo and active drug. So we see that this drug has a very fast onset of action on pruritus. After 2 weeks, most of the improvement on pruritus is already seen if you compare 2 weeks to 3 months. So what's interesting as well is that with the JAK inhibitors, we have comparator trials, so we can really see how these drug performs in terms of pruritus as compared to dupilumab. And what has been shown is that in terms of onset of action, and dupilumab is in green, so in terms of onset of action, the 2 abrocitinib doses are superior to dupilumab. So the onset of action on pruritus is much faster than dupilumab. However, over time, if you look at what's going on after 3 months, then dupilumab is in between the higher and the lower abrocitinib dose. So that difference is not as important, and there's no difference anymore between the low abrocitinib dose and dupilumab. Upadacitinib, so again, change from baseline in terms of pruritus NRS, superior to placebo. As early as week 1, we see the difference. And again, you see the onset of action. You know, most of the changes you see by week 4, and one could argue that by week 6 to 8, you're probably at maximum efficacy on average for patients. Comparator trial showing the upadacitinib 30 milligrams, so the higher dose as compared to dupilumab, and showing that in terms of worst pruritus NRS, it is better than dupilumab, and you see that the shape of the curve again, it improves faster. But over time, at week 16, it is statistically superior. So proportion of patients with pruritus in RS01, again, what I call real good control of pruritus, regardless of how it is calculated. I think that if it's 0.1, it should be good control. So we are as high as 34.8% in the UPA group as compared to 15.6 in DUPI. However, we need to recognize that there's no placebo group. And often in clinical research, when there's no placebo group, the efficacy seems to be bumped up a little bit. So nemolizumab, I'll first show this slide about the Japanese study that was published a few years ago in New England Journal of Medicine, because it compares placebo to nemolizumab. What we see is the onset of action on pruritus seems to be very fast, specifically for a biologic, and it was superior to placebo at week 16. Now, we had 2 days ago the phase 3 data presented at this meeting for the first time with nemolizumab. However, what they decided to do for phase 3 is to do a combination trial with TCS. So it's more difficult to evaluate those trials because the TCS combination trials in ED are all done in a different way. So it's another area where you cannot compare to another TCS trial. And this trial specifically, what they did is they did a run-in period of 2 to 4 weeks with TCS, which is, which includes a patient population that is a TCS, a real TCS non-responder patient. It's not only based on history. What they found was that in terms of pruritus, you have a significant difference between the TCS only, placebo, the TCS placebo, and the TCS nemolizumab group. and it's statistically significant very early on, as early as week 1. And now, again, we look at the 4-grade decrease in peak pruritus NRS, and we see the difference between the combination with nemolizumab and the combination with placebo. So this is my second to last slide. This is obviously incorrect from a scientific perspective, but I decided to do this because it's fun, and it's a comparison of the studies conducted with drugs that are published or in phase 3 with biologics or oral drugs for pruritus, showing the difference in efficacy. I've worked with most of these drugs, not all, and in my experience, this is probably true. So the baricitinib 2 is not very effective. The upadacitinib 30 is very effective. Dupilumab is probably, fairly similar to lebrikizumab. Tralokinumab is a little lower. So I think this gives us a good idea. One thing that is interesting as well is if you look at this, and if we would do the same thing with IgE 01 or EZ, we would probably have the same grading. Now on my last slide, what I consider unmet need in future research, where I would suggest we should do more, where companies should do more. First, patients with severe pruritus but limited active AD. And we see these in our practices. So patients come in, they're not that active, but when you do pruritus NRS, it's super high and they have sleep issues and sleep problems. I think we should better characterize these patients. What's the role of topical drugs in these patients, of pruritus drugs, maybe a drug like nemolizumab that target a cytokine that is key in terms of pruritus. In addition, we see patients with moderate to severe AD with an excellent response to systemic agents, but with significant residual itch. So in practice and in clinical research, when we ask patients that we see are doing super well, many patients still have pruritus NRS of 5 or 6. So we need to better characterize those patients. What's the proportion of those patients? Do we see many with 7 to 10? And again, what would be the role of topical drugs or maybe adding systemic pruritic drugs? And finally, pruritus remission. So we're talking more and more about AD remission, but I would like to see data on pruritus remission as well. Thank you.
Robert, thank you so much. I just want to start with the last slide you put, because these are exactly the patients I also see in my center, those who are under treatment. Eczema is controlled, but itch is still there. And I think all what we discussed before about the brain and the nerves, and this is something that is established in them, and that in this individual patient, the biologic or whatever we have in the patient cannot control really these mechanisms. And I think this is the interesting population where we need to do the studies on the nerve fiber functioning. And thanks for the great overview. So in many talks, when we are talking about itch, someone stands up and says, you did not talk about topical therapy. What's about that? So I guess this is why all are sitting and not coming to the microphone, because you very nicely presented that. So let me circle that back. How do you as audience feel about the topical JAK inhibitors? Will they replace the TCS or the TCI? So if you don't ask us questions, we ask you. Mette, thank you.
Yeah. One brave person, I'm not surprised.
I think it will be very interesting to see. We don't have so much experience with it here in Europe. There are trials on hand eczema, for instance, for the topical JAKs. For some patients, it works very well. And I think it would be really nice to be able to use the topical JAK stats, maybe in combination with some of the biologicals, because we have some patients who have residual eczema or residual itch, and I think it would be nice. We also discussed whether we should combine different systemics, but I think if we have access to these topical JAKs, it would be so nice to try to combine with the biologicals or other systemic drugs.
I completely agree. So there are a few investigator-initiated studies that are starting and will start in the US on psoriasis, so patients on biologics and psoriasis, because most of these drugs have been approved in psoriasis, and others are to come as well on atopic dermatitis, because I think this is really a key question. Yeah, the last thing maybe I want to mention, and then maybe I'll introduce our last speaker because we want to keep on time. The study I presented about the single center study we were involved in terms of treating patients with ruxolitinib. One thing that is really interesting about that study is that we did a lot of techniques in order to understand the effect of this topical drug on itch. So these patients had skin biopsies, tape strips, microbiome. So in the coming months, you will probably see some data on this. We have a lot of this type of data with systemic agents, but we don't have much with topical, so it will be interesting. So if everybody's in agreement, I'll introduce our last speaker. Good. So our last speaker is Dr. Zink, who is a consultant physician at the Department of Dermatology and Allergy at Technical University of Munich. He's a dermatologist. He specializes in chronic skin diseases, has a strong interest in digital medicine. His research interest focuses on prevention and on burden of disease, and he will be talking about influence of itch on quality of life and happiness in atopic dermatitis patients. Dr. Zink.
Yes, so thank you for the kind introduction. Thank you for having me. It's a great pleasure to be here and to talk about happiness. And you can imagine with my last name, I'm very used to being the last one on stage. So I will be even more try to make you happy at the end of this session. These are my conflicts of interest, and I would like to start with a question for you. What would you choose? Would you rather be rich or happy? Who is for rich? Who's for happy? Who's for a combination? So I hope you all are. And in fact, obviously, that's what people decide. The main goal in life for most of us is happiness. There are many, many studies on it. And in fact, there are a lot of studies that happy people live longer. Happy people are more productive. Happy people have less diseases. They have better relationships, greater success, improved mental and physical health, and so on. And eventually, what governments across the world do, they try to find out what's happiness in their respective country and how can the people be made more happy. Bhutan, most of us know Bhutan, a kingdom where happiness is more valued than the GDP. And even in Germany, Angela Merkel, she tried to work on happiness, how to make the German people more happier. And do me a favor, scan this QR code, and on your way home, listen to Robert Waldringer. He has a 85-year-long ongoing happiness study. And he will answer the question, what makes a good and happy life? And I will not tell you the results because he's an amazing storyteller, and I promise you, you will look at it once or twice and maybe 3 times. But at the end of having looked at it, you will say, oh my, why are we not looking into happiness in atopic dermatitis, in chronic inflammatory skin diseases, and in itch? Why are we focusing on SCORAD, EASI, PASI, and so on? Our patients have much more which affects their lives. And probably most of us will agree that looking at this patient receiving a systemic treatment against itch, it's a very good treatment for him. He looks very, very, very happy, doesn't he? So the question is, how do we use happiness as a patient-reported outcome? What is happiness? Can it be used as a score? How does happiness influence itch? How does it influence atopic dermatitis? And how does it influence the treatment outcome, but also the disease outcome? The big problem is we do not know how to define it so far, and the big question is, how do we measure it? And looking on PubMed, you will find several explanations on how to measure happiness and different aspects of happiness. And you could give a patient 275 questions, do a beautiful study, and then find a score of how happy he or she might be. But obviously that's not the point, because the longer a questionnaire obviously is, the less happy our patients are. One one approach is, or how the United Nations do it, they look at the overall GDP and different aspects, and every year they have the happiness report. And you might know that the happiest people live in Finland, in Denmark, of course, in Iceland, but also here in Miami and in Münster and Montreal, I heard. Those are the hotspots for happiness. I am a big fan of this simple question. How happy are you in general? Also called heuristic happiness, from a scale 0 to 10. And think about it, how happy are you in the moment, in this exact moment, or within the last few days? Take a moment to think about it, and we'll do the average, we'll count it, okay, it's about between 6 and 7. That's where most of the people are. And obviously you can't compare my happiness to your happiness, but you can compare your happiness over time. So it's always about comparing your individual pattern with yourself over time. That's the key of happiness as I see it. When you have an academic approach, you would define it as happiness differentiating between being lucky, which is also part of happiness, being happy, but then of course being happy, because the lucky occasion, it's hard to influence. The being happy, it consists of positive emotions and negative emotions, or no negative emotions, overall satisfaction with life, overall happiness with life, which then can be influenced. Measuring happiness and health, how we see it in Munich is to objectively measure positive effect, negative effect, and then satisfaction with life. There are a couple of scores, PANAS in Spain, and then the SVLS, the satisfaction with life score. And we did it, we compared people with chronic inflammatory skin diseases in Munich with healthy controls, with patients suffering from chronic inflammatory bowel diseases, and comparing them to patients suffering or being HIV positive. And the positive controls, the healthy controls, it was compared to psoriasis, atopic eczema, numerous eczema, mastocytosis, and skin cancer, melanoma, and keratinocyte carcinoma. And I will take you to the results. So the first interesting finding was that patients with skin diseases experience less positive emotions, but not significantly more negative emotions compared to the healthy controls. On the other hand, patients with skin diseases consider themselves less happy than healthy controls, and within the different chronic inflammatory skin diseases, and compared to HIV and the chronic inflammatory bowel diseases, the patients with atopic dermatitis, they reported the lowest levels of positive affect and the lowest level of heuristic happiness from a scale from 0 to 10. So the next step, and of course what's very interesting, but what we know from dermato-oncology is that patients being healed from a cancer, they're very happy, they're very satisfied with their life, because obviously they have a second chance. So the next thing is what we did is we compared our concept of happiness with the DLQI. And what we saw is that the DLQI correlated with the overall happiness and with the quality of life, but only with the negative emotions and physical quality of life. But that's exactly what the DLQI asks for, right? Because when we remember the Dermatology Quality of Life Index is a disability index measuring the skin-related quality of life impairment. Quality of life, on the other hand, consists of psychological, social, environmental, and physical quality of life. And happiness, as I mentioned, the three facets, the positive affect, the negative affect, and the overall satisfaction with life. So you have something here which so far we are not covering in our patients, especially with chronic inflammatory skin diseases and especially in patients suffering from itch. Next step, of course, we ask the question, patient with AD, how does the AD affect your happiness? And this, on the one hand, it's not really astonishing that over 90% said yes, AD is affecting my happiness, but also 9% said AD is not affecting my happiness. So what's the difference? What AD patients are happy without the AD affecting their happiness? towards the majority of people who really are affected and less happy with AD. So we did a number of correlations and looked at different parts of happiness and parts of different score. And to summarize it up, the longer AD persists, the longer the history of AD, coping strategies probably apply, and the longer somebody is suffering from AD, the more positive effect he feels again. And also the current skin condition, the improvement, that's a major outcome for positive effect, major influencing the positive effect. On the other hand, the negative effect is mainly influenced by disease severity, severe and moderate diseases, and especially, of course, in itch. On the other hand, satisfaction with life, again, the longer that you suffer from the disease, the more you probably cope with it, and then you get happier again. Current skin condition improvement, that's the major finding for satisfaction with life, and also here for the overall holistic happiness. And I'm very interested in patterns and not looking at one single time point, not looking at one questionnaire, but a combination of different patterns. So we did a huge study with a lot of patients with chronic inflammatory skin diseases, and then looked at the age, the heuristic happiness, satisfaction with life, positive aspect, negative aspect, quality of life, physical, psychological, social, environmental, and total, as well as hope, optimism, resilience, self-efficacy, and an overall score. And here you can see the summary of the pattern, but here's the summary of the patterns of patients affected by psoriasis compared to atopic eczema. This again, mastocytosis, because we have a huge center for mastocytosis in Munich, keratinocyte carcinoma, malignant melanoma, and numerexema. And have a close look. It's not about the color blue or red on a single spot, but it's about the overall pattern. And you see that the pattern for psoriasis is similar to atopic eczema, but that the negative effect clearly stands out in atopic eczema because of the itch, whereas in mastocytosis you have a completely different pattern. And that's eventually the finding why I believe that the one-item happiness questions, how happy are you at the moment from 0 to 10, is very powerful, because you can compare an individual with his individual understanding and in terms of his or her happiness, and not combining one with the overall population. In AD, of course, we know that itch is the most bothersome symptom, and this clearly also affects then the happiness and the patterns I showed you of positive effect, negative effect, and satisfaction with life. And Matthias Augustin, he really nicely showed that the patient needs, number one, is be free of itching. So it's really about the itch which is influencing the whole life, and then of course also satisfaction of life and happiness. And we did another study, so we're doing a lot of internet data mining, and the European populations, we use Google, we use different forms of social media, and we were interested, what are people who Google for symptoms, for information about atopic dermatitis, what are they interested in? And it's a very busy slide, it's also published, but what I wanted to show you is it's an itch. Itch is the number one symptom people are Googling for information connected to atopic dermatitis. So again, it's the most bothersome symptom, and they even Google about it at night the whole day, because it's really affecting their whole life, and of course then their happiness. And as we all heard in this amazing session of the IEC, it was about how do we objectively measure different things, and how do we continuously measure things in microbiome, for example. And I think technology will be able to help us. And have a look at this figure. It's already 2 years old, which is a long time in terms of technology. And all of the devices you see, there are prototypes on the market. So you have smart lenses, for example, continuously measuring the intraocular pressure. You could have a t-shirt objectively measuring the scratching areas we saw in the previous lecture. But also here, for example, the smart patches and microneedling patches, which continuously monitor biomarkers. And there was an amazing publication last year. They developed a biosensor, a wearable beyond measuring glucose in diabetes, and they were able to show that it's possible to real-time monitor amino acids. So just imagine you have a wearable device you put on your patient, and then you can have his or her amino acid pattern connected with itch, connected with any other things you want to have a look at, and you will get an individualized approach to treat him or her with his or her disease. And the next step then is beyond continuously measuring the human machine is the smart home. And we talked about the smart bedroom maybe, because how do you objectively measure sleep and sleep disorders and sleep impairment? Well, why not have a smart mattress which gives you a score, how good your sleep is, how bad your itch was, for example. And I believe that within the next years we will see a very powerful smart bathroom, turning it into the middle of medicine maybe, because we will have, I believe, a smart mirror, and it will give us information. What is the weather like in Berlin? Are the shoes the right shoes for this huge Messe here at the EADV? But also, it will be able to detect with the eye the skin diseases we have, and for happiness, we were very interested here in the mood detection. So there will be a mirror telling us if we're depressive, telling us if we're happy. And imagine depressive people, and that's the biggest market actually, especially in the United States. It's people with anxiety, not leaving their house, depressive people not leaving their house, to track themselves and then to alarm their psychiatrist maybe. And for happiness, it would be an amazing tool to see what's the overall happiness. And probably you all agree, we don't need a score for this patient. We don't need a questionnaire. We see he is happy with his treatment, and obviously his itch is treated very, very well. So on the other hand, we now can say, okay, happiness is important and happiness is impaired in patients with AD, especially by the itch. But what do we do about it? Are there also additional ways to interact in addition to the amazing treatments we have and which we are presented? And I brought two positive psychology interventions, just like it was shown for itch. And if you try, or if you want to become a bit more happier, try the happiness diary. There are amazing studies on it, and it showed that if you do a diary for 10 weeks and just mark how happy am I today, this increases your optimism, you're satisfied more, it reduces your physical complaints like headaches, and the more grateful individuals were, the better the mood, sleep, and even heart health, and probably also itch, but so far there wasn't a study on it. And you shouldn't do it every single day. Don't do the diary of misery, the diary of pain, telling yourself how miserable you are every single day. Tell yourself how happy you are, and once a week, then it has the highest output, and do not analyze it, just take it as it is and document for yourself how happy are you, because the events were reported but not analyzed. That was more effective than in terms of happiness. And a random act of kindness, that is also something I really, really like. What is it? There's good deeds that are not directed toward anyone specific, but aim to bring joy to fellow human beings without expecting anything in return. So often the giver may not even be aware of whom they have brightened up, but the studies have shown it has a positive effect on the givers as well as on the receivers. So just imagine our board coming up and there was a flower. No one knew who puts the flower there, but everyone would be happier and nicer, and it's like, oh wow, I'm amazed. And maybe you remember the last time you were at a vending machine and you found a small coin somebody forgot. Do you remember that moment? Did it make you happy? Definitely it did, and that's why a typical random act of kindness could be put some change in the change box of a vending machine, and it would make the lady or the man after you very, very happy. So in summary, itch is severely affecting ID, it is severely affecting happiness. And don't itch, be happy. That's something probably we can say, what we need much more studies to understand what happiness is and to understand the happiness or the impact of itch on happiness in AD. Thank you very much.
Good. Thank you. Very interesting presentation. Mette.
Thank you very much for this wonderful lecture, Alexander, and I really enjoyed. But I sometimes wonder if it makes people more happy to be monitored all the time, because I think I'm of course of an older generation than you are, but sometimes I get worried because I think maybe if you have to monitor 15 things a day, you might get more stressed with it. Do you have any results on that?
Yes, so there are good results that actually there's also a term for teenagers not finding their phone or smartphone. They stress out after 15 to 17 minutes. And of course that also might be the same with wearable devices. And I always remember my grandpa when he asked me, what am I doing with this phone? Back then I told your grandma, I am meeting you at the church at 7, and everybody was there without texting I'm late or whatever, because you just waited there. That's a problem for our society maybe, I don't know, but yes, so at the moment the one idea is to continuously measure us from head to toes, but you also find the time-out movement basically, the digital time-out movement, leaving your home, putting all away the technology. So eventually we might up somewhere in the middle, and like with any technological advantage, like with a car, there will be some new problems, and we have to decide how do we want, as a society, how do we want to use these wearables.
Thank you.
I have a practical recommendation to all the drug pharma to include it as a secondary outcome, happiness of using your drugs. I think it's easy to do. It's sometimes more interesting than just doing all these analyses of, and I think it's very meaningful for our patients. Not a daily happiness diary, I agree, but it coincides well with the well-being. Patients' happiness is a well-being factor.
So I have a question in the same direction. I'm involved in many clinical studies in dermatology, not only atopic dermatitis, and I can't remember a protocol where we measured happiness. So my question is this something that is popular in other areas of medicine? Is this done in other areas of medicine, maybe in psychiatry, but outside psychiatry, or are all specialties like us?
Actually, it's not common at all, and just look at psychology, psychiatry, it's a negative psychiatry. So psychology, you can depression, you have different categories of depression, but happiness, we have one category. So that's a field of positive psychology, and that's just the upcoming field at the moment. And that's also what the governments actually do now at the moment. And the German Society of Positive Psychology is really, really small, but they're getting bigger and bigger. And happiness is just one approach, and there are many, many other fascinating approaches.
Good. Another question. Go ahead.
Yes, thank you very much for this wonderful presentation.
Thank you.
In my opinion, you can increase the happiness by education of the patients, because knowledge means power, and non-knowledge means anxiety. So we do the education school in patients, and I think this really leads to a better quality of life.
So I agree, but I also disagree. I think it's a mixture, because of course for some people, including me, knowledge is safety. Because when you know how something works, then you're confident and you know how to use it. On the other hand, knowledge can also be frightening. You can also know what can happen. You could die being on an airplane, and if you think about it, some people might get frightening. So I think it's a mixture, and I think it depends on the personality more or less, but overall I agree, of course.
And I think both of you are right. And it's just on the selection of the right words. We are here in a space of verbal instructions and verbal programming. And if you try to do psychoeducation and give them a flavor of more positive things, as you said, not focus on the negative things. And there I absolutely agree to you. There we have a powerful instrument that we can further use in patient education. Not in clinical trials, then we have too much placebo effects.
Well, a good example is the smart mirror. So imagine you would have a mirror and it knows what you think. The AI tells us what we think. There was a Nature study out last year, and they showed that it is possible for an AI to look at the non-invasively measured activity of the brain and tell what this patient is thinking. So we will be there at some time. If you have not heard about this study, that AI can read your brain, you wouldn't worry about it. But now, as you know that AI can read your brain, you might be scared. And that's why, again, I fully agree. It's about twisting or communication, but the same communication can be interpreted differently from different people.
Just a comment on the positive effect related to the treatment benefit. And we didn't measure happiness in the dupilumab studies, but we did measure well-being. We had a question for the patient, how the disease influenced their well-being. And then we look at what is the perception of the treatment effect. And these both go together. So was happy to see that this is really one of the things that patients consider when they consider happiness.
Yeah, happiness and well-being, of course, go hand in hand. I think they're a bit different. So happiness for me is a day at the Munich Oktoberfest. Wellness, well-being is a day at the wellness resort. It's different, and that's why I think that people really love to go into stadiums, because it's happiness overall. It's more than well-being.
Depends.
On the show. Okay, thank you.
Yeah, I think, Alex, you made us happy.
Thank you.
And we are very happy with the talk, so thank you again. And now we are at the end of this session. I hope we could convince you that only the topic of atopic itch is very rich, and we came from the interleukins, we saw what the nerves do, what the brain is doing, and how the brain is processing happiness, and a very important topic for us all were the topical therapies and the systemic treatments. We had very good discussions, so I feel connected to this group, and I hope that we catch up again, see you again, have more discussions. What was the next topic in... What was the next topic you have? It's all around atopic dermatitis, but it's not the itch. It's another fascinating topic.
So the next topic for the next IEC symposium is basic research methods in atopic dermatitis research, ISID.
Yeah, so you see, we are expanding again. And yeah, with that, we can close this session. We're happy that you stay here until the end, and we hope that you have a safe journey to your home. Goodbye.
I was not tired. That's good. That's reassuring. Oh, now you are happy. Now you are happy. Yes, I'm always happy. But you know, it's also necessary to be good, to have a little bit humor. Humor. Humor is so...
I want to don't take oneself so serious. Right? Yeah. It's a pity that...
Lovely to meet you. I'm running, but...
It was really